Hi y'all, welcome back to my channel. If you're new here, hi, I'm Linnea, and this is the video that I wish I could have had access to a year ago when I first suspected that I developed gastroparesis. I want this video and the others in this series to be a resource for anyone who wants to learn more about this rare condition, and especially those who have been diagnosed, are searching for a diagnosis, and those who have been denied a diagnosis. In my quest to fully understand the causes, symptoms, diagnostic tools, and treatment options for this rare disease, I have spent the past year researching gastroparesis every chance I could get. I created this video series to make it easier for others searching for answers to access comprehensive information about this condition from a variety of perspectives, including other sufferers with the condition, doctors who treat this condition, and scientific researchers who are looking deeper into the symptoms and etiologies of the disease. All of the resources that I used to create this video are linked in the description below so that you can access the full versions of any of these videos or articles. I have also linked the content of a few other creators of gastroparesis whose videos I have found helpful in the past year. All three of these women have gastroparesis due to Ehlers-Danlos syndrome, but they each manage their symptoms very differently. Izzy, like me, manages her symptoms with dietary changes, nausea medication, and supplements such as CBD oil. Kenna relies on motility and nausea medications, a feeding tube for enteral nutrition, and a modified diet. And lastly, Lindsay uses a primarily liquid diet, medications, and TPN, or total parenteral nutrition. This video will cover the definition of gastroparesis, as well as the causes and symptoms, and especially why this condition can be so difficult to properly diagnose. I will make subsequent videos diving deep into the treatment, or rather symptom management options for this condition, so stay tuned for that. This video will focus primarily on non-diabetic and idiopathic gastroparesis, since that is the type of gastroparesis that I believe I have, and thus the type of gastroparesis that I've researched the most and can provide the most comprehensive information about. We will also discuss functional dyspepsia in detail, since recent research suggests that the two conditions are much more alike and intertwined than previously thought. As far as the definition, gastroparesis at the simplest understanding is what it sounds like. Gastro meaning stomach, and paresis as in paralyzed. Some people with gastroparesis have a fully paralyzed stomach. However, in most people with gastroparesis, solid foods and liquids are still able to leave the stomach, albeit at a delayed rate. Some may call this partial paralysis, but the best way to understand it is as delayed gastric emptying with no evidence of any mechanical obstruction. And according to NORD, the National Organization for Rare Disorders, gastroparesis is, quote, an old term that does not adequately describe all the motor impairments that may occur within the gastroparetic stomach. This graphic from Clinical Nutrition University on YouTube shows some of the different ways that gastroparetic stomachs can be impaired. NORD also makes this very important statement about the way the term gastroparesis is used clinically. Quote, there is no expert agreement on the use of the term gastroparesis. Some specialists will reserve the term gastroparesis for grossly impaired emptying of the stomach while retaining the label of delayed gastric emptying, or functional dyspepsia, non-ulcer dyspepsia, for less pronounced evidence of impaired emptying. These terms are all very subjective. There is no scientific basis by which to separate functional dyspepsia from classical gastroparesis except by symptom intensity. In both conditions, there is significant overlap in treatment, symptomology, and underlying physiological disturbances of stomach function. It is important to me to point out this concept because we will revisit this idea many times during the course of this video, especially when it comes to discussing the diagnostic options for gastroparesis. The symptoms caused by gastroparesis can significantly impact quality of life, as has been my experience with the condition. NORD states that the condition is disabling for 1 out of every 10 sufferers with gastroparesis. As far as the number of people with this condition nationwide, estimates vary from source to source. The article that Capital Digestive Health put out for Gastroparesis Awareness Month explains, depending on which studies you read, between 500,000 to 5 million Americans may suffer from it. But other research from the National Institute of Health suggests that this may only be the tip of the gastroparesis iceberg. Researchers have concluded that many people have undiagnosed gastroparesis because patients experience a range of symptoms similar to those of other diseases such as GERD and celiac disease. I have linked both that article and the study reference entitled Prevalence of Hidden Gastroparesis in the Community, the Gastroparesis Iceberg, which suggests the condition is much more prevalent than is currently thought to be the case. The study is certainly worth a read to gain a better understanding of how many people could truly be suffering with this disease. And according to an article by the Cleveland Clinic, cases have been on the rise since 2014, especially with young women in their teens and 20s. Part of the difficulty in having good statistics on this disease lies in the different understandings of what qualifies for this diagnosis in clinical practice. Many of the conditions that have overlapping symptoms to gastroparesis even have some associated degree of delayed gastric emptying, but do not quite qualify in clinical practice for the gastroparesis diagnosis. The causes of gastroparesis are best broken down into three categories: diabetic gastroparesis, idiopathic gastroparesis, and non-diabetic gastroparesis. Type 1 diabetics have a higher risk of developing gastroparesis than type 2 diabetics do. According to Dr. Freakray, a PhD who studied the connection between Ehlers-Danlos syndrome and functional gastrointestinal disorders, in her article titled Mistakes in Gastroparesis and How to Avoid Them, states, quote, "The presence of gastroparesis in the setting of diabetes is a consequence of autonomic neuropathy that results from a long-standing poor control of blood glucose levels as well as from daily fluctuations caused by episodic hypoglycemia. Idiopathic gastroparesis is gastroparesis that has no known cause or no clear identifiable cause. People may be initially diagnosed with this type of gastroparesis before the cause is found, although plenty of people do stay in the idiopathic category for the full duration of their struggle with the disease." Nord provides additional insight into idiopathic gastroparesis by explaining, quote, "Approximately 80% of idiopathic cases are women. Idiopathic gastroparesis may be linked to an as yet to be elucidated enteric autoimmune disease." The Cleveland Clinic article delves deeper into the autoimmune condition theory, as they have found unusual antibodies in the nerves and muscles of some of these idiopathic patients after screening their blood for autoimmune disease markers. They also found potassium channel, sodium channel, and myasthenia antibodies using a blood panel test called an autoimmune GI dysmotility diagnostic panel in those women that presented as idiopathic gastroparesis. The known causes of gastroparesis that can result in non-diabetic gastroparesis include but are not limited to post-viral, post-surgical, opioid-induced vagus nerve injury, which could be the result of surgery, and this is also post-surgical, and neuromuscular or neurological disease such as Parkinson's or multiple sclerosis, and connective tissue disorders such as scleroderma and Ehlers-Danlos syndrome. The three content creators that I referenced at the start of this video all have gastroparesis and other GI issues such as intestinal dysmotility due to hypermobile Ehlers-Danlos syndrome. The symptoms of gastroparesis can develop slowly over time, as mine did, or occur suddenly. In some cases, the symptoms literally appear overnight. Sudden symptom onset is more common in post-surgical and post-viral gastroparesis, but it can happen to anyone. Many idiopathic cases cite sudden symptom onset as well. The main symptoms of gastroparesis, as in the symptoms used to diagnose the condition, are abdominal pain, which can range from pressure due to fullness or sharp piercing pain, which is potentially the result of abdominal spasms, nausea, bloating, vomiting, regurgitation, acid reflux, early satiety, getting full quite quickly, especially that's not in proportion to hunger or caloric needs, prolonged fullness after eating, loss of or lack of appetite, excessive belching, and many blood sugar regulation issues. Many patients also develop GERD or gastric reflux disease in addition to their gastroparesis. Lower GI symptoms such as constipation occur in some patients with gastroparesis, but not all. The symptoms of gastroparesis range in prevalence, frequency, and severity from patient to patient. Many people with gastroparesis also experience weakness, chronic fatigue, brain fog, and other issues related to inconsistent nutrition. For me personally, I experience most of these symptoms daily. I am constantly struggling to get proper nutrition through prolonged abdominal pain, food aversions, lack of appetite, early satiety, and nausea. Due to my chronic intestinal dysmotility, I have to make sure I'm regulating my bowel movements, or that condition will exacerbate my gastroparesis. The only symptoms that I may not experience daily are vomiting, regurgitation, and acid reflux, but if I'm in a flare clear, sometimes I vomit up to 10 times a day. It gets really exhausting over time, especially when I'm already frustrated and weak from not getting enough food. It's difficult to mentally push myself to eat enough when I know the more I eat, the sicker I may feel, even on a moderate symptom day. Everyone's experience of this disease is different, and it is generally agreed upon in the clinical and research community that the severity of symptoms is not correlated to the severity of gastric emptying delay. This is especially true of diabetic gastroparetics, who can have severe delays in gastric emptying but also be asymptomatic or have quite mild symptoms aside from blood sugar spikes and lows. Additionally, a person can have severe gastroparesis symptoms even if their delay in emptying is mild, and even an intermittent delay can cause vomiting and nausea in some people. As I mentioned earlier, the symptoms of this condition overlap with the symptoms of many other conditions, which makes a correct diagnosis even harder to achieve. It is important to pay attention to the subtle differences in the related conditions. The key related conditions that I want to highlight are cyclic vomiting syndrome, cannabinoid hyperemesis syndrome, rumination syndrome, and functional dyspepsia. There are other seemingly mimicking conditions, but these are the ones I want to focus on today. These conditions are mentioned in many other sources I have cited below, but the two doctors who do the best job of illuminating the differences are Dr. Ficre in her article and Dr. Lisa D. Lin in her speech at UCLA. Dr. Ficre makes some great distinctions between cyclic vomiting syndrome, cannabinoid hyperemesis syndrome, and rumination syndrome, while Dr. Lisa Lin focuses on the more closely related condition to gastroparesis, which is functional dyspepsia. Full versions of both those resources are in the description, but I'll provide summary here. Rumination syndrome is characterized by, quote, effortless regurgitation, mainly postprandially. This is a behavioral phenomenon caused by subconscious abdominal contractions that cause the regurgitation of food back into the esophagus. The distinction from gastroparesis here is that the regurgitation occurs directly after eating, sometimes even while eating, to the point where the food tastes exactly the same as it did during consumption, and the food is often swallowed back down. The regurgitation is also typically small amounts of food and may not actually be preceded by nausea. In contrast, vomiting in gastroparesis can occur many hours after eating and can vary greatly in both the amount and the violence which with it expels. However, if you have this condition, it is still possible that you also have gastroparesis. Some people, like myself, have both gastroparesis and rumination syndrome. There are times where I effortlessly expel food right after eating, as occurs in rumination syndrome, but there are also many more times when my vomiting will occur hours after eating and be quite forceful. Cyclic vomiting syndrome and cannabinoid hyperemesis syndromes have purely episodic symptoms. They both cause, quote, episodic attacks of vomiting that usually last for a few days and can be associated with dehydration and electrolyte imbalance. In between episodes, patients are completely asymptomatic, which is not the case for patients with gastroparesis. Although Dr. Ficre does mention that these symptoms, or syndromes, can be associated with gastric emptying delays as well. As Dr. Lin explains, functional dyspepsia and gastroparesis are the hardest to distinguish between. She even advocates the two conditions based on a spectrum with lots of areas in between rather than as two distinct diagnoses. In fact, 30% of patients with functional dyspepsia diagnoses have some degree of delayed emptying. She suggests that these patients would receive much better care if doctors focus on a wide range of medications and therapies to treat a patient's most bothersome symptoms rather than to hone in on what medications are indicated specifically for gastroparesis versus functional dyspepsia. I agree with her that the conditions are much more accurately viewed on a spectrum, but I'm slowly going to discuss Dr. Lin's insights about the subtle differences between the two diagnoses here. Patients with functional dyspepsia typically have one or more of the following symptoms for more than 3 months: bothersome postprandial fullness, bothersome early satiety, bothersome epigastric pain, and bothersome epigastric bloating. The symptoms are not necessarily meal-related. Functional dyspepsia has two subtypes: postprandial distress syndrome, which is characterized more by the early satiety and postprandial fullness while being more meal-related, and epigastric pain syndrome, which is characterized more by epigastric pain and burning while being more meal-unrelated. Functional dyspepsia can also involve nausea, bloating, and belching, but vomiting is atypical. Patients who who present with these symptoms plus vomiting and like a lot of nausea are much more likely to have gastroparesis. Dr. Lin provides this excellent chart that shows the breakdown and the differences between the symptoms of gastroparesis and functional dyspepsia. Nausea, vomiting, loss of appetite, weightless, and malnutrition are much more common and pronounced in gastroparesis than in functional dyspepsia. Someone with severity in any of those symptom categories is more likely to have gastroparesis than functional dyspepsia. You will note this is the first time I have mentioned weight loss as a symptom of gastroparesis. Weight loss should never be seen as the primary diagnostic category for gastroparesis and is in fact considered a more rare symptom of the disease by many doctors. For me personally, I have not experienced consistent weight loss or significant weight loss even though I have had intense symptoms for over a year. Due to the chronic fatigue, weakness, and pain that gastroparesis causes me and many others, my activity level has dramatically increased from when my symptoms first started. My lack of consistent or quality nutrition has also contributed to severe muscle mass loss and muscle atrophy. Both of these factors have dramatically decreased my metabolic rate and have led to a lack of the weight loss that some might assume would come with severe gastroparesis symptoms. Another really important reason that someone with gastroparesis will either maintain weight or gain a significant amount of weight has to do with the fact that the reality of our condition makes healthy eating nearly impossible. This has been my experience with the condition. I often supplement calories with treats and snacks because those foods are usually the easiest on my stomach, and I know this is the experience of a lot of others as well. Patients can have extremely severe gastroparesis and be heavier than they were prior to gastroparesis symptoms starting. And this is just as valid as it is for those who lose weight due to the condition. For more information on the gastroparesis diet, I suggest the video Gastroparesis, Emphasis on Diet and Nutrition made by Clinical Nutrition University, in addition to the gastroparesis guidelines from the Cleveland Clinic and the information from the Mayo Clinic about gastroparesis, which provides detailed diet guidelines as well. I have linked all 3 resources in the description, but I will provide summary and information from my experience here. In general, people with gastroparesis are encouraged to eat a low-fiber, low-fat diet. They are discouraged from eating raw fruits and vegetables, especially with skin. We are also discouraged from eating whole grains, full-fat dairy, nuts, legumes, higher-fat meats, and fried foods. As you can see, the majority of the foods that we are told not to eat at all or to limit portions of are healthful foods. Most of them are also foods that are considered good for intestinal function and overall health. This can be especially complex for people like me who have both gastroparesis and intestinal dysmotility. I often find myself having to choose between stomach pain and backed up intestines. I have to ensure I get enough fiber for my intestines to move waste along, but I also have to eat that fiber in small portions from only foods that I can tolerate without overly bad symptoms, and I cannot tolerate much fiber at all in the evenings after a full day of trying to eat. Another piece of advice given to people with gastroparesis symptoms is to consume smoothies, blended soups, or other types of mashed and pureed foods. For me, those foods, especially smoothies with raw fruit and blended vegetable soups, make my symptoms much worse and typically induce vomiting. I theorize this is because blended meals allow me to consume a lot more fiber in a short period of time without chewing, and chewing is also an important first step in the digestive process, and thorough chewing can actually help improve gastroparesis symptoms, as can eating smaller, more frequent meals, as many patients are advised to do. Every single person with gastroparesis will find different foods and meals that work for them and that don't work for them, as a lot of creators I have linked below explore in their videos, and as I will explore in my future videos on this topic. Gastroparesis patients have the impossible task of trying to balance proper nutrition with symptom management, and marrying the two can be impossible for many people without additional interventions such as medication or even surgery. You can imagine that being encouraged to eat many snack-sized meals throughout the day that are often void of fruits, vegetables, whole grains, and even full-fat dairy, a person could easily get sufficient calories from nutrient-poor sources and even maintain or gain weight and still be malnourished and have terrible symptoms to deal with, and be trying to overcome the stigma of being told their symptoms are not as valid as a thin person with the same disorder. Clinicians claim that malnourishment is also a rare outcome of this disease, but I would argue it is much more common than weight loss, as it occurs in gastroparesis sufferers of all sizes and severities of gastroparesis delay. Most doctors still do not recognize the more subtle signs of malnourishment, including brain fog, fatigue, cognitive impairments, metabolic slowing, and muscle loss that many gastroparesis patients experience, in addition to the other more gastrically located symptoms. For someone to be officially diagnosed with gastroparesis, their doctor has to collect empirical evidence they have delayed gastric emptying, as well as no mechanical obstruction that is causing their symptoms. An endoscopy is normally done first, as was the case with me. In an endoscopy, they will look for mechanical obstructions as well as other issues such as ulcers that could be causing symptoms. If food is found in the stomach during an endoscopy that a patient would have to be fasted for, that would be a big indication that gastroparesis could be present. Following an endoscopy, gastric delay can be proven with either of 3 tests: a gastric emptying scan, a breath test, or the SMART pill test. The breath test and the SMART pill test are rarely offered to patients, but I will briefly explain them here. The best information that I found about the breath test was from a clinic that offers it called Huron Gastro, located in Michigan. I have linked their website below, and this is how they explain the test. Quote, "You will need to consume a special meal in our office. This meal contains spirulina, a plant-based product, that has been modified to contain a special type of a carbon molecule called carbon-13. Carbon-13 is a completely safe form of the element carbon. As you eat the meal, the spirulina is metabolized and carbon-13 becomes present in your exhaled breath. Our staff will be collecting samples of your breath before and after several times after the meal to determine the amount of carbon-13 you are exhaling over a period of time. These samples will then be analyzed and used to determine how well your stomach is emptying." At their office, the test lasts for 5 hours, and they advertise it as a non-radioactive alternative to the gastric emptying scan. The SMART pill test is rarely offered to patients because it is expensive and insurance often will not cover it. However, it has the distinct advantage of passing through the entire digestive system and tracking transit time through the small intestine and colon, as well as the stomach. As far as I know, the only one available in the US is the Medtronic SMART pill, and it's a wireless capsule. I have linked their website below. They describe their product as an ingestible capsule that measures pressure, pH, transit time, and temperature as it passes through the entire gastrointestinal tract. The sensor-based capsule allows for the GI functional assessment with a single test and provides valuable diagnostic information, including gastric emptying time, colonic transit time, whole gut transit time, and pressure patterns from the antrum and duodenum. This test is not considered standard yet, mostly because it is not widely used due to expense and thus is not seen as the ideal option for a gastroparesis diagnosis. The test that is literally referred to as the gold standard test by both doctors and patients alike is the gastric emptying scan. If you have been diagnosed with gastroparesis or are seeking a diagnosis, chances are that you will have completed or are about to complete a gastric emptying scan. I have had this test myself, and this is how it went for me. I had to fast prior to the test, and I could not even drink water the morning of the test. My test started at 9 in the morning and lasted until 2 in the afternoon. It was a 4-hour test. My test started with a meal of white toast, egg whites, and jam with a small glass of water. The egg whites were laced with a radioactive substance that would be used to track the movement of the food through my stomach. I had an x-ray with my arms over my head at the 1-hour mark, the 2-hour mark, and the 4-hour mark. After my scans, I was allowed to go home and wait for the results. The test works by tracking how much of the radioactive substance remains in your stomach after each scan and comparing the percentage of the meal you retained to the amount you initially ate to see if you have abnormal gastric emptying. In my case, the test showed normal emptying, and I was denied a gastroparesic diagnosis. It turns out that many people, not just myself, are misdiagnosed as a result of this test. This test that people consider the gold standard for diagnosing gastroparesis, which is awful because this test often determines the level of care and concern that many patients receive regardless of the severity of their symptoms. On February 3rd, 2021, a study entitled Functional Dyspepsia and Gastroparesis in Tertiary Care Are Interchangeable Syndromes with common clinical and pathological features. It was published in the Journal of Gastroenterology, authored by Dr. J. Pasricha and others. Dr. J. Pasricha is the director of neurogastroenterology research at Johns Hopkins University. I have linked the article itself as well as the results and as well as the discussion of the results in the description. Both are worth a read. I will go ahead and summarize the study and the results discussion here. This study was done to provide more clarity on the diagnosis of functional dyspepsia versus gastroparesis. Two patients can have the exact same symptoms and symptom severity, but if one of the patients shows delayed emptying on a gastric emptying exam and the other one does not, the patients will be subject to two different diagnoses and in many cases, two different modes of treatment. Most practitioners, despite the aforementioned words of Dr. Lisa Lin, treat functional dyspepsia patients with a much lesser level of treatment options and concern than patients that show gastroparesis on a gastric emptying scan. This study revealed that gastric emptying scans are truly only a snapshot in time of the way a person's stomach emptied on a particular day at a particular time, and that when repeated, the diagnosis can easily be reversed in either direction, regardless of the degree of gastric delay initially shown. Another test a year after the initial scan in this study showed that many patients that had a severe initial delay had their diagnosis reversed even though their symptoms had not become less severe over time. This test studied 944 patients with chronic upper gastrointestinal symptoms. The patients were followed for 48 weeks in multi-center registry studies. Patients were classified as having gastroparesis if gastric emptying was delayed. If not, they were labeled as having functional dyspepsia if they met Rome 3 criteria. Of those in the study, 720 or 76% were diagnosed with gastroparesis, and 224, 24%, had a diagnosis of functional dyspepsia. For everyone in this study, severity of physical symptoms were highly similar and mental symptoms were also taken into account and found to be highly similar as well. For example, all the patients, regardless of diagnosis at the start of the study, had scores that were similar for quality of life, anxiety, and depression. This was tested because, unfortunately, patients with functional dyspepsia are sometimes told their symptoms are psychosomatic, which happened to me. After 48 weeks, 249 of the patients were retested with a gastric emptying study, and the results were staggering. Quote, overall, 41% of this cohort could be categorically transferred from one group to the other after 48 weeks, see Table 3. Of 189 patients with a diagnosis of gastroparesis at baseline, 79 or 42% had normal emptying at 48 weeks, thus no longer satisfying the definition of gastroparesis. Conversely, 60 of the patients with functional dyspepsia, normal gastric emptying at baseline, 22 or 37% showed delayed gastric emptying at 48 weeks, thus qualifying for the diagnosis of gastroparesis. These findings hold true irrespective of etiology, as 41% of the idiopathic and 39% of the diabetic population undergo a change in the diagnosis of functional dyspepsia or gastroparesis after 48 weeks. Further analysis confirmed these patients were not just borderline cases that narrowly met the criteria for gastroparesis. Even 27% of patients with extreme gastroparesis, so more than 50% gastric retention at 4 hours, were shown to have normal gastric emptying at their second scan. All symptom management techniques had stayed the same throughout the entire study for everyone who received a repeat gastric emptying scan. Overall, this study argues that gastric emptying is not a reliable marker to distinguish between these two conditions. The researchers state, quote, our study shows that movement between the two groups can be in both directions. Patients with normal emptying can exhibit delayed emptying when tested at a later time point, and vice versa. Further, gastroparesis patients across the spectrum of delay were similar in their frequency and conversion to functional dyspepsia, and therefore this was not a phenomenon confined to those close to the cusp. between delayed and normal emptying. Our findings indicate a significant lack of reproducibility of gastric emptying, either due to intrinsic limitations in the test methodology or because gastric emptying in a given patient may vary highly over time. This study also proves that the rate of gastric emptying has no bearing on symptom severity, even for functional dyspepsia patients, which are typically seen as having a less severe condition, which this study proves is frankly not true. To further clarify, the researchers state, quote, "Our results reinforce the concept that gastric emptying studies are of limited utility in patients presenting with symptoms suggestive of gastroparesis/functional dyspepsia." However, we realize that this area is of considerable controversy, and corroborative studies by other investigators are encouraged to provide validation or not of this statement. At the same time, we would like to emphasize that we do believe that both gastroparesis and functional dyspepsia represent neuromuscular disorders of the stomach, even if gastric emptying measurements do not capture the accurately. In the discussion of the study, Patrick Smith quotes, "Their reclassification had nothing to do with the severity of their symptoms." Patricia explains, "They just happened to take the test on a day when their results were different." Sharing this study is so important to me because even though I'm a person with intense gastroparesis symptoms, I am often not taken seriously because one test on one day that captured only 4 hours in time with one virtually fat-free and fiber-free meal didn't show that I had gastroparesis. I want others to know that the gold standard test is not something that either patients or doctors should put on a pedestal. Gastric emptying is variable based on much more than even the type of meal eaten. And anyone with gastroparesis will tell you they experience good days and bad days, as well as periods of frail flares and partial or even full remission of their symptoms. Whether you have been diagnosed with gastroparesis or functional dyspepsia, if you identify with the daily uncomfortable, life-altering physical and mental symptoms of stomach dysfunction, these videos are for you. I would love to go into detail on all the symptom management approaches for gastroparesis here, but this video is already quite dense. There will be a part 2 where I go into detail on all the possible treatments for gastroparesis that I'm personally aware of after a year of research and listening to the stories of others with the condition. The word treatment is a tough one to use because sadly gastroparesis has no cure, and there is no way to predict whether this condition will get better with time or get worse over time. This video is just the start of many videos on this channel about gastroparesis, and I will be making a part 2 that goes into much more detail about symptom management and treatment options, including like some more herbal, natural interventions that I personally use. So subscribe and like and comment to see part 2, although part 2 may already be up when you watch this. I'm trying to post it like a week from today. Thank you for watching, and I cannot wait to keep talking about gastroparesis itself, as well as my personal experience with this illness. If you have gastroparesis or functional dyspepsia, I want you to know that you are not alone, and I hope that these videos can provide some level of comfort and understanding for those with this illness. Thank you for watching, and I will see you in my next video.